And it is a view of echocardiography. You can see the blood jet just through the defect in the septum. By the way, echocardiography is very important in cardiac surgery, both for diagnosis and for the intraoperative assessment. This video chip shows the patch repair of a large VSD. Interrupted suture are anchored around the rim of the VSD. The marker shows the site of the AV node. Great care should be taken over here to protect the conducting system. Otherwise, AV block will occur. Stitch by stitch around the rim of the VSD. And it shows the conduction system. Great care is taken here because it's near the conduction system. RBB and RBB shows the conduction system. After placing of these sutures, a patch will be anchored to the VSD. And now, the sutures are passing through the patch. This is the comparison of a patient, the chest film before and after the operation. You see, the left one shows the preoperative chest film. You can see pulmonary plethora of pulmonary congestion on the film. After the operation, the lung fields become clear, and it needs time for heart to shrink to normal size. And this slide shows another disorder. It's called pulmonary stenosis. Pulmonary stenosis is a form of a right ventricular outflow tract obstruction in which the stenosis is usually valvular. This is most commonly seen, or infundibular, or trunk. The physiology of a PS, that is a pulmonary stenosis, is different from the shunt disease. You see, if the patient with a pulmonary stenosis, of course, it must be moderate to severe degrees. For mild degrees, the patient will have no pathologic change. In the patient with pulmonary stenosis, you see the pressure in the right ventricle will be increased, and then in turn this will cause right ventricle hypertrophy. In the long run, right heart failure may happen. At this time, patient will have peripheral edema, even ascites. Also, the blood volume in the lung is decreased due to pulmonary stenosis, so the cardiac output will be decreased. The patient will have symptoms like effort dyspnea, even syncope. Stenosis may appear in severe cases. Therapy is simple. We cut the stenotic we cut the stenotic valve open. It's called valvotomy. But nowadays, interventive technique has been taking the place of a surgery. It's called balloon dilation. Finally, we are going to say a few words about a complicated heart disorder. It's called tetralogy thalatt. Tetralogy means the 4 pathological changes of the disease. That is obstruction of RAOT and a very large VSD, and overriding aorta over VSD, and hypertrophy of the right ventricle. And this slide, I think, is a little bit difficult to understand. Just remember, all these pathological changes is the consequence of the underdevelopment of subpulmonary infundibulum. That is why the aortic valve comes to lie more anterior and superiorly and rightwards relative to the pulmonary valve than usual. And this, the end development of the subpulmonary infundibulum results in a narrow lumen of a pulmonary artery, so less blood flow through the pulmonary valve and the pulmonary trunk, so that these structures are usually hypoplastic. And this slide shows the pathophysiology in tetralogy. You see, patient saturation of oxygen is decreased due to the right ventricle outflow tract obstruction and dysplasia of pulmonary artery. Also, right to left shunt through VSD exaggerated the decrease of oxygen saturation. So the patient will have cyanosis. Clinically, we can see the clubbing of fingers and the polycythemia, that the increase of hemoglobin, and the cerebral thrombosis, even cerebral abscess. So the patient will experience lower physical tolerance. Sometimes the patient may have a situation called cyanotic spell. This is ischemic in brain. People may have a syncope or even death due to the cyanotic spell. Another situation is that the poorly developed left ventricle due to the blood flow in the pulmonary is decreased greatly, and this situation making one-stage repair difficult. So for repair of the disease, correction is the first choice, but if the patient have underdeveloped left ventricle, two-stage therapy must be used. So the left picture shows the clubbing finger, and the right one shows the typical chest film is called boot-shaped heart. Therapy. So surgical correction primarily remains the only option so far. With modern technology, almost all of the simple congenital anomalies can be treated surgically or interventively with very good long-term results, with very low operative mortality rate, less than 1% for ASD closure, for example. Majority of the complicated anomalies can be treated with the surgery primarily, though staged procedures are needed in some cases. The incidence of the complicated congenital anomalies is decreasing nowadays. This is the end of the part 2. Thank you very much.